Good morning, welcome to the Doctor on Call at the Parking Lot. I'm Dr. Maximo Gomez-Nacer, and today I want to discuss neurology. And this is for the purpose of the United States medical licensing exam and for the test of the real life. The first case is a 65-year-old man that comes with hemiparesis. There is a weakness into the right side of the body, the right leg, the right arm, the right side of the face. The person also have hyperreflexia into the right side. And the question is, well, what we are going to do now. Usually, basically the patient has a stroke in this case, and we will have to differentiate between embolic or a hemorrhagic stroke and trying to figure out. Now, for the purpose of the general knowledge, what we have is we have three main arteries: anterior, medial, and posterior. The phrasing in English that says "put your best foot forward" can be used in this case as a mnemonic to identify or to remember, if you will, where is the location. So, for example, best foot forward. Forward would mean anterior. So the anterior cerebral artery actually produces mostly the innervation to the foot. Now, the middle cerebral artery will produce in this case mostly to the arm and to the face. And then we have the posterior cerebral artery. The posterior cerebral artery, we simply follow whatever is left, meaning a cross syndrome. The cross syndrome means that there is hemiparesis to the right with fascial involvement to the left. In this case, we are talking about the Weber syndrome. The Weber syndrome includes hemiparesis with cranial nerves involvement in the opposite side of the face. Or we have the Benedict syndrome, which would be, in this case, hemiparesia, also cross, with ataxia in the opposite side. Right? So, if the question is, what is our next step? The next step is to do a CT scan with no contrast. That would allow us to differentiate between hemorrhage or a stroke, and we already have where to look for which one is the arteries that should be involved. Now, also we have to conduct tests to identify, for example, in the case of embolism, we have to think about atrial fibrillation, which is the most common cause. So we look for doing an EKG. Also, we are looking for doing an echocardiogram to try to identify if there is any embol source produced by either a turbulence or valve problems or any other difficulty in the heart. So an echocardiogram is also some choice. At this point, in the initial evaluation, we don't have to do a TEE, transesophageal echocardiogram. It's not necessary at this point. But we should do a carotid Doppler. In the Doppler, we're looking for specific signs of stenosis that can be producing this stroke. Particularly, we're looking for occlusion. What is the level of occlusion? For the purpose of knowing, this is just the procedure for usually the carotid endarterectomy. The criteria is 70% in the for symptomatic stroke. If there is a symptomatic if there are signs of focalization and there is more than 70% occlusion, then that is an indication of endarterectomy. On the other hand, people can have even 90% of occlusion without symptoms. In that case, we require more than 90% in both arteries to make the recommendation of endarterectomy. Now, having said that, we review, well, we have the EKG, the Doppler, and we have the echocardiogram. What else we should do? Sometimes we don't get the atrial fibrillation initially, and we have to put a 24-hour Holter monitor to see if the patient, if the source is an embolus, for example. Having said that, then that is in general aspects of a simple case to identify a stroke. Now we can, let's see, figure out a simple other case. It is a patient that is 55 years old and comes, in this case, with altered mental status. Whenever we hear altered mental status, either confusion or the patient is not himself for whatever reason, we have to figure out where is if there is any focalization. Focalization meaning any aphasia, any symptom of either sensory or motor, and that is the important aspect that we're going to do. Now, aphasia, by the way, we can have the aphasia Broca or Wernicke. Broca, we can see, is generally broken. Think of Broca as broken, or in Spanish as boca. So basically the patient cannot speak properly. It's not easy to understand language. However, the Wernicke in aphasia will be a person who cannot understand, and basically you can ask something, the patient answers something different. Or let's say, yes, you say, repeat for me, this is a beautiful day, and the person, instead of saying that, they say this is a Tom day or something like that. They don't understand the language. It's difficult to understand. So those are the two aphasias. Focalizations are easy because simply we do a proper physical examination and we identify if there is any area of motor or sensory deficit. Now, with this scenario, we also realize that this patient in particular is coming with nystagmus. Now, the nystagmus is the movement of the eyes, and particularly everywhere we look, we have to actually look and then go back. The fast component is what is referred as a nystagmus. So, for example, let's say the differential diagnosis in this case, we have to differentiate something which is central or something peripheric. Whenever a patient comes with the keyword nystagmus, we have to differentiate, is this something central? Is this something peripheric? Well, the patient has some altered mental status, so it points towards something central. But in this particular case, we have to also review the history. Let's say it's a patient that has a history of alcohol abuse, or is taking convulsing and is taking phenobarbital for some other reason. It's not disclosed to us. We assume maybe epilepsy. And then it comes with the nystagmus. So in this case, what we had to do is actually to immediately do the interrogatory, right? Now, the nystagmus, the fast component, when it's unidirectional only, in one direction only, points towards something peripheric. Peripheric meaning, for example, labyrinthitis or benign positional vertigo, or any of the conditions that are associated with hearing loss. Now, this is the fast component. When we have a person that has the fast component in different directions, is more than one direction, then usually we think it's something in the brain. Now, another element we can have here is the purity, if you will. So, if it is complex, simple complexity is referred to having more than one axis, looking up and down and looking to the sides. If the person has multiple forms, it's not just to the right, but it's to the right and to the left, then we are going to again think in the something at the level central in the brain. Also, we can ask the patient simply, look at this finger. Now, when the patient looks there, the nystagmus, if the nystagmus disappears, this is an indication of something peripheral. If the nystagmus remains, is present, it must indicative of something central. Now, also we can figure out for the history if something that starts progressively in a long time can point, for example, to the tumor, and something that starts rapid can point, for example, to an infection like a tinnitus, for example, for something localized peripheral. Now, these are in general some of the aspects that we can look in the evaluation of the nystagmus. And of course, we have to check if the person is taking some other drugs. In this case, the drug is taking convulsions associated with that, and we didn't find anything in the CT scan, we didn't find anything in the drugs other than the excessive drug. So it was actually very high level. So in this particular case, the answer was to decrease the drug to a therapeutic level that is not toxic. That was the particular question in that case. Now let's say another case comes with a patient that has a complaint that is, the patient says, I cannot walk properly, doctor. Now when you evaluate the patient, you find out that there is a weakness in both legs, and it's mostly from the level T10 down, and the patient has hyperreflexia in both legs. But most importantly, the patient is mentioning the keyword incontinence. So whenever you find out this word incontinence and you associate it with a specific focal symptom, in this particular case it was saying that it has a belt-shaped sensory level. So you say, how come it's going to be a belt shape? How come it's going to be to the right and to the left? Well, whenever this happens, we have to think in a spinal compression, and it's an emergency. Therefore, the next step, they ask you, what is the next step? And they will try to trick you into going and doing an MRI or something like that. The next step, as soon as you identify and you suspect that this is a spinal compression, you immediately recommend give steroids to produce some anti-inflammatory level to give time for the surgeon to come and to evaluate the patient, because of this key element of incontinence, either urinary or fecal. Now, in the next step usually is an X-ray. So we can have an X-ray, a spinal X-ray, to identify where is the compression, actually to identify. In this case, they say it's going to be T10. But the next step then, it will be an MRI. So these are general elements that have been asked in these questions. So what else? We have to differentiate sometimes between a spinal compression and some vascular problem, some peripheral vascular disease, some actually embolism to the spine. Now, how we differentiate that? We usually use the interview. For example, a patient that has had some trauma, we're going to ask, we are doing a physical evaluation, of course, but if the patient comes with a trauma, we can immediately suspect an hematoma. If the patient comes with fever or with white blood cell counts increase, we can immediately think that this is an abscess that is producing the compression there. If the person is coming with a history of some cancer, particularly those cancers that produce metastases to the spine, for example, lung, breast, prostate, colon, we immediately think that this is secondary to a tumor. And so the management is different. We initially provide the steroid, but then the types of management will vary from that moment on. Now, another form, it can be, for example, a patient that is doing an exercise, and that particular time didn't do the exercise by lifting vertically, but by lifting, bending in 90 degrees the body. And this will be then most likely a sacrolumbalgia and basically one of the discs will be herniated. So these are the elements for the compression. Now, what happens with the elements of a vascular disease? In general, it's difficult to find it, but generally, if they give us, the person that writes the question has to guide us in some way. So if we read something that is a risk factor, let's say cigarette smoking, hypercholesterolemia, high blood pressure, prolonged sedentary lifestyle, this kind of keywords will tend us to think mostly into a vascular problem then. So instead of a compression, we should think now in a peripheral vascular disease. Now, there is another patient that this is another case. In this case, a patient that comes with palpebral ptosis. and which is the descent of the upper eyelids. And also it states during the interview that this was happening, particularly when he's eating. It has at some point has to leave the food because he is too tired. Now, these two keywords give us to immediately in neurology, of course, we are thinking ptosis papilla, immediately think Eaton-Lambert, or we can think in myasthenia gravis. Now, how we differentiate them? We can differentiate them. The Eaton-Lambert is a syndrome that is associated with with weakness. And in this case, the source most likely is identified as a keywords and association with a particular type of cancer in the lungs, which is the small cell carcinoma. So whenever we see Eaton-Lambert, we have to do this association with lung cancer, and particularly the small cell carcinoma. Not the squamous, no the adenocarcinoma, no other kind of carcinoma, this particular type. Now, when we have a patient that comes, on the other hand, the myasthenia gravis is also associated with something particular in the thyroid. So hypothyroidism may be the association of the myasthenia gravis. So if they ask you what would be the next step, we have to do, usually we do a test injecting neostigmine or physostigmine, which is an anticholinergic medication, basically blocking the acetylcholinesterase. It's an acetylcholinesterase inhibitor. So what happens is in the myasthenia, the physiopathology is basically antibodies against acetylcholinesterase, against acetylcholine. Therefore, the person doesn't have the neurotransmitter acetylcholine, and therefore then it produces a weakness. Now, when we provide this medication, the person improves, and right there we immediately think, what is the initial test? That would be the initial test, providing the neostigmine, for example. Now, the next step can be, for example, if we read in the choices, testing antibodies against acetylcholine, that would be another choice. Or if they ask you what is the best test, the most sensitive test, in this case would be to do electromyography. And with the electromyography, we will see the pattern that is typical for the myasthenia gravis. Also, they can ask you what would be the next step in management. Whenever they're giving us management, or steps, we think in management first. We can think, for example, once you put the treatment, the neostigmine, by the way, will be the treatment. We can also, if the patient doesn't improve, we can do a plasma, remove the plasma of the body to remove the antibodies, plasmapheresis. And if that doesn't work, we also have to remember to actually do a MRI or check if the person has a thymus, because in many of these cases for the myasthenia gravis, it has been identified that the person has a thymus that is in some way associated with these antibodies to the acetylcholine, and we had to remove the thymus, not just to eliminate the source of this antibody, but also to prevent becoming a cancer in the thymus. So this is a prophylactic surgery to remove the thymus. So this is another of the facts they want us to know as part of the evaluation of these cases. So in general, these are some of the questions that we have in neurology. We're going to continue seeing more of these cases during the next. I don't want to extend too much in the types of questions, because then it's going to be difficult to download the videos. But anyway, this is all for now. Come to the next video. It's even better, well, in terms of facts for this test. And well, I hope you find it at least useful if you come and do this, if in doing the United States medical licensing exam is what you want. Thank you very much, and have a wonderful day.